pain, there's a tissue injury type of pain, or primarily a neuropathic type of pain. For example, diabetic pain. Diabetic neuropathy, there's no tissue injury, but nerves are injured, so they give pain. Again, we can divide them into two categories according to the chronology. Arbitrarily, less than 3 months old pain, more than 3 months old pain. So less than 3 months old pain is acute pain. More than 3 months old pain, or pain which lasts more than 1 month after the resolution of whatever initial injury, is called chronic pain. Chronic pain is more neuropathic. With time you get sensitization changes and they have features of neuropathic pain. So in summary, acute pain is more of physiological pain, a nociceptive sort of pain, tissue damage sort of pain, and treatment of disease cures the pain, and it's self-limiting. There's a simple relationship between pain and the tissue damage, and the proportionate to the clinical finding. Whereas chronic pain now is mostly neuropathic, because now changes have taken place in the nervous system. Chronic pain is more neuropathic, so it's more than a symptom now, it's a disease. Nervous system has changed now. So this difficult treat. It's difficult treat. There's a dissociated relationship between the tissue damage and the pain now, because the patient is already sensitized, and this is disproportionate to the clinical findings. So if somebody asks you, is pain an alarm? Yes, it's true for acute pain, but may not be true for chronic pains, because it may be a disease now. So then we can actually combine these two classifications together and say acute nociceptive sort of pain or chronic neuropathic pain without tissue damage, but in between you will see a transition sort of patient. Right? They have both nociceptive component elements as well as neuropathic elements. So with that in mind, talk about chronic pain management. So in any management plan, the most important thing is the diagnosis of the etiology. We have to find an etiology, then treat the etiology as well as the pain. But we don't know where exactly the patient lies, acute on the acute side, on the chronic side, or in between. Whatever it is, treating underlying problem is very important, otherwise it will give disastrous outcomes. The next thing is assessment of pain. So no patient is going to be treated for hypertension without taking their blood pressure. That happens every day, except one fortunate reasons. But then no pain patient is treated after being assessed. So you don't know how you treat. So when I was at one lab, that's why I started actually doing this thing. There are patients coming with 4 exercise books full of CST, continuous same treatment. And they have been prescribed with NSAIDs, paracetamol, and then gastritis treatment. And it would have costed many thousand rupees actually. And ultimately, they are suffering from the same problem. Same patient comes next visit, getting the same treatment, going back to the same thing, and half of the treatment will be thrown out because they know it's not going to work. So that is actually a pathetic story. So every time we will have to assess pain. It's a dynamic process. So next time if he has more pain, we have to escalate. The less pain, we have to de-escalate, otherwise the side effects of the treatment. Right? So pain is a dynamic process. Always we will have to assess it and then treat. The next important thing is treating in a timely manner. As I said, so acute pain is not managed properly. Next time when it comes, it is a chronic pain after 3 months. Now it's a difficult problem to address. So there are various methods of assessing pain. Pain is a subjective thing. There is no objective of assessing it. So patient describes it. It's the best way of doing it. But sometimes patients cannot describe things like the patient is drowsy after trauma or something like that. Then you have to go by non-self-reporting. Level of patients, distress, cardiovascular involvement, blood pressure, tachycardia, whatever, we can assess them. But patient self-report is the most important thing in chronic pain management. So, for assessment, we can get various pain scores, numerical ratings, 0 to 10 or something like that, adjective as mild, moderate, severe, or as a visual and low rating. Important thing is, if you extrapolate the results, they have not been changed. And the other most important thing is, we are not worried about numbers actually, we are worried about change of these numbers. So next time when patient comes, he has more whatever or less, that is the important thing more than absolute number. However, having said that, sometimes in specific populations, pain assessment is difficult. Like elderly people can't hear, can't talk, can't understand what we say. children similarly, certain ethnic groups. So for specific population you are catering, you have to devise a pain assessment, whatever method yourself. Because you are not going to treat everybody. You must be treating either diabetic patients mostly or arthritic patients. So specific categories you see, you have to devise your own method and keep on doing with that method. So this is what I am doing actually in my medical pain clinic actually at Badula. So the first step basically we assess the severity of pain, we assess the type, whatever the pattern of pain, which will give a clue to a diagnosis. The third part is basically to differentiate between neuropathic and nociceptive pain. So go through this question, the burning, feeling, pricking, touch, the allodynia part. If you get the full score of more than 18 in this, basically they have a neuropathic pain.